Hear the latest reporting and analysis on the big stories of the day on the Daybreak Insider podcast. It's top-notch reporting from SRN News, along with the sharpest insight from Hugh Hewitt, Mike Gallagher, Dennis Prager, Sebastian Gorka, and the voices of townhall.com. The Daybreak Insider podcast. It's your first look at today's top stories. Available at Apple Podcasts, Spotify, Google, and at SalemPodcastNetwork.com.
Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So, let's get started with your host of the show, Mike Buck, and Medical Director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
Well, welcome aboard. Glad you can join us. As a matter of fact, we've done been climbing up the ladder a whole bunch of these shows, and today's show is a real good one, because when we talk about varicose veins, and it conjures up all kinds of different things and different people and different stages, and as we've learned from Dr. Juleff over the time that we've been doing the show, there's any number of stages of this. And today, which I really love, is we're going to talk about 3 different case studies of varicose veins. And these are the kind of folks that see the veinclinicshawaii.com all the time. And if you're going to be one of those today, it's going to be because you're going to learn some stuff that we hope is valuable to you. So nice to see you again, Doc.
Thank you. Good to be here.
You know, it is sort of interesting because I do know that if you have there's a toothache and there's a toothache, right? There's one that makes you scream and one that you can't scream because it's so sore. And I'm guessing the same thing with varicose veins, in that you've explained, you know, over the past couple of years of shows, that what we're doing is something, this is a progressive disease. It starts and it goes along. But there's all kinds of different stages of it. And that's why we get to maybe delineate what some of those are today.
Right. Yeah, you know, when people say, gee, I have varicose veins, luckily varicose veins are one of the signs of, you know, what we call venous insufficiency, which, you know, we always talk about the fact that varicose veins are just the tip of the iceberg.
Yeah.
You know, that's just another sign and a symptom of a problem with the function of the veins that are deeper in the leg, and that's the root problem. That's the crux of the problem that's going on. But you know, people come in with varicose veins, and a whole lot depends on, you know, whatever else is going on with that patient. Varicose veins might be just, gee, I've got, you know, relatively new varicose veins. I've had them for a few years. I've got some symptoms, and you know, we take care of it. It's a pretty easy fix, and they go away happy, hopefully with a smile on their face.
Well, you know, one thing that I've come to learn since we've been doing the show, and I think this is very valuable to me, and I'm sure to a lot of our listeners, is that, you know, as you look at this, it goes way past being a cosmetic inconvenience. I mean, you know, spider veins, but when varicose veins, like what you said, is they're indicative of something else is going on inside your body that's a lot worse. Yeah. And if you didn't have varicose veins, you may not even know that that's going on.
Right, right. We get that question all the time. And I mean, people will come in and say, well, gee, doc, all I've got are a few varicose veins. I don't know if I'm overreacting. And the answer to that is no, you are not overreacting.
Especially if there's symptoms, right?
Well, especially if there's symptoms. But, you know, invariably, if someone has varicose veins, they have that underlying vein functional problem, and that needs to be addressed because it is a medical problem.
Okay.
But so anyway, let's start with our first case study, who is a 45-year-old guy, and he works as a cook. So he's on his feet all day long, all night long too, probably. But you know, he spends many hours each day on his feet, which, as we've learned in the past, is one of those risk factors for developing vein disease. And he presented to us with a primary complaint of varicose veins of just the left leg. So he reported that he had been developing those varicose veins over about a 10-year period. Each year they get a little worse.
This is not strange for you, though. 10-year period. I mean, that's a newcomer.
Yeah.
Right. In my case, we're looking at 40 years.
The process. Well, the process probably starts at a very young age because vein disease typically the primary initiating feature is genetic. So I think it's probably not uncommon for people with a strong family history, especially to start developing things in their 20s, certainly in their 30s, and they don't really even recognize what's going on until it gets a little worse, with as time goes by.
Okay, so this guy, the first guy we're talking about today in these 3 studies, is right up that median. He's right at 45.
Yeah. For most of that time, they didn't really bother him very much. He wasn't having symptoms. He thought it was mainly an aesthetic thing, so he, didn't really pursue being evaluated and possibly treated. But over the prior, let's say year to year and a half, he had started developing symptoms. He had achiness, heaviness, easy fatigability of that left leg in particular. So he was taking note. He was identifying the fact that he was having these symptoms in his left leg and not his right. And the achiness, heaviness, fatigue thing are 3 very, very strong indicators of venous insufficiency. Those are 3 symptoms that we look for all the time. He started developing some throbby kind of pain, especially in the area of the varicose veins, and it started to interfere with his ability to work all day long in a comfortable kind of fashion.
And for men, I think that's the biggest reason why people will come and see you. I mean, women, and bless them and love every one of them, they're a little bit more cosmetically oriented than we are. But when you all of a sudden are at work and standing, and your boss tells you to go do something and you can't get there very fast, you think, this is starting to hurt me, financially as well as pain.
Yeah, I think that men in general, they probably wait for more symptoms than women do, and they probably present a little later than most women. But eventually they come to the conclusion that they need to have it looked at. But so his primary care physician had seen him at some point and said, "Gee, start wearing compression stockings," which is a good thing. And he found that by the end of his work day, when he was wearing stockings, his leg felt quite a bit better. So
that's incentive. I'm the same way. You know that.
The same way. For sure. Stockings come through again, as we always say. But he had then started to develop a little bit of ankle and foot swelling. When he wasn't wearing his stockings. So, when he was wearing his stockings, his leg felt better at the end of the day, and also when he was wearing a stocking, he didn't have as much swelling in the ankle and foot. And I think that that's probably what, for some reason, swelling seems to be a big symptom or a significant issue for people with respect to symptoms of venous insufficiency. I mean, they can put up with a little bit of discomfort, achiness, and even the fatigue. They kind of tolerate, or they chalk it up to other things. They chalk it up to age or whatever. But when one or the other extremity starts to swell, that makes it a little more concerning in their mind. So I think that was kind of the thing that really brought him into the office. So his past medical history was unremarkable. He was on no medication. His weight was normal. So pretty, like you said before, a middle-aged guy, pretty healthy, very active, not really no other significant medical issues. So family history. His mother had a fairly extensive varicose vein history of both legs.
Oh, yeah. Me too. Thanks, Mom. Bless you, but thank you, Mom. Sure. Yeah.
She had never had them treated. We usually ask about that. He does remember during her elderly years, she would wrap them occasionally with ACE wraps because that made them feel better. Again, just like compression stockings do.
Though you explained to this a while ago, and gang, this is an important point. The problem with the ACE bandage type of thing is that you put them on and they may be nice and snug, but then they start stretching a little bit. Mm-hmm. So what they're doing is they only work for a minute, and then they start working less. Whereas the compression stockings, they stay at the same level all the time. Pretty big difference.
Yeah. I think for sure ACE wraps are nowhere near as resilient and long-lasting as a good pair of compression stockings. And then the other thing is, you can wrap your legs with ACE wraps or whatever, but you're never exactly sure how much compression you're giving yourself.
Sure, yeah.
Like we've talked about before, stockings are constructed in a very specific way to give you the exact amount of compression that you want or need in any particular patient. So the mother had it, so there's family history. He came in, we talked more, we got an ultrasound, which we usually do, and we found that his right leg was normal. The underlying vein function, superficial and deep venous systems of the right leg were perfectly fine. Left leg, he had reflux in both what we call the great saphenous and also the small saphenous vein.
Now, just remind everybody, the reflux is what you're talking about, is the inability of the blood that is down at the bottom of your body, usually, coming back up.
Right, yeah. Which is, that's the mechanical problem. That exists when people have venous insufficiency, and that is that veins in our legs have one-way valves that keeps the blood moving in the right direction, which is upward, and those valves fail. And incidentally, the propensity for those valves to fail, that's the thing that we inherit. That's the genetic component. So,
but is it real quickie also?
Yeah.
Because you said that it's basically one leg was kind of normal, the other one was not.
Right.
Is that typical? As far as I can remember, most of the time we talk about it's not the typical varicose veins. Usually if you have varicose veins, both legs.
Well, yes and no. We often see people come in with non-symmetric or asymmetric findings in their legs. They may both legs might have. They may even have the same amount of venous insufficiency in their superficial or even deep venous system, and it's not unusual for one leg to be a fair bit worse than the other.
Okay, gotcha.
Now, why that is, I don't know. It probably has to do with how one leg works more or less than the other, and
when you're right-footed, left-footed, right-handed, left-handed.
Yeah,
whatever,
and what activities, their daily lifestyle, et cetera. So, but that is not uncommon at all where we see that. And for whatever reason, again, one leg is a little further ahead in the timeline of the whole process. But and usually. They are symmetric in that, both legs still have that propensity to develop venous insufficiency because the genetic influence on one leg is the same as the other. So eventually they will probably develop those problems. But, again, it's not unusual for them to come with one leg looking quite a bit worse than the other. But so the ultrasound showed reflux in the two main veins of the what we call a superficial venous system. There's two systems of veins in the legs, superficial and deep. His deep system looked fine, which is what we see in most people, which is good because we can treat that a little more easily. And the ultrasound showed no other abnormalities. So what did we do? Well, for this guy who was pretty straightforward, we did what we call endovenous ablation on the two saphenous veins, the great and the small saphenous vein, and we used a radio frequency device. Radio frequency is just an energy source. And when we say endovenous ablation, we mean that we're closing that vein down. We're ablating the vein. We do that with heat. That's what the radio frequency catheter generates. It generates heat. So we heat up the inside of the vein. The vein closes down. So we're sort of cauterizing the vein from the inside. Now, why do we do that? Well, we do that because when we close the vein down, it stops that abnormal flow pattern. If the vein is closed, it can no longer, the blood can no longer go in the wrong direction. And it also forces the body to reroute the blood to normal veins. So, so that's really what we're doing. We're forcing the body to reroute blood to normal veins so that the normal vein will send it back up to the heart the way that it should.
And, gang, the thing that I find spectacular, especially if, and many of you listeners we know have got vein issues from an earlier generation or two. And the treatment and the diagnoses and everything is dramatically changed. And when you talk about this ablation, I think it's fascinating to let people know that you have this tiny little wire that goes right up that vein.
Right.
And up to where it's needed. And then the heat is applied and it does its thing. Yeah. Now, and this used to be, if you're going to get rid of that vein, a surgery. Where you had to cut and pull and move and this thing, you put the little wire up there, you heat it up, and it's gone.
Yeah. That we do that in the office, and it's a 30-minute procedure, and people leave the office and go on with their day, as opposed to what we used to do is what's called surgical vein stripping, and people came in the hospital. They were there for 2 or 3 days. They had a general anesthetic and a lot of incisions and healing and stuff. So, the process has been improved pretty significantly. But so that's what we did ablation for the two underlying problems. That's the root cause. But we then get rid of the varicose veins by doing something that we call ambulatory microphobectomy, and that's just a fancy term that means that we extract those bulgy veins. Now, we used to again make big incisions. We don't anymore. We make just little small, very very small, tiny little needle puncture sites, and through those puncture sites, we have special instruments. We go in and we extract the varicose veins. They come out in segments, which is not a problem. I wish they would kind of like pull out like a long piece of spaghetti.
Yeah, I was hoping for that too when I had mine done. Didn't work that way. But by the same token, every single instrument, every single technology that's used now is so dramatically changed. Because I remember my mom, she would go through, like, her stomach would be upset for a week before her visit to the doctor, just because it was just so uncomfortable. And then later on, just before she passed away, and she had some work done, in her late 80s, no problem.
Right. Using the newer technique.
Yeah, she couldn't believe it.
Yeah. It's been a world of difference, and it's been good for everybody. So that's it. We ablate the underlying problem. We do microphobectomy to get rid of the varicose veins, and that gives you that eliminates the underlying pathophysiology, which is the reflux in those saphenous veins, and it gets rid of the superficial. Which the varicose veins they're medically related because they in and of themselves they can create symptoms. Yep. Number one. Number two, if you don't remove them, in my mind, now some people don't. Some people who treat this problem leave varicose veins behind. They might ablate those saphenous veins, but they leave the varicose veins behind, and in hope that they go away. Well, they in my mind, they never really do completely go away, and they can create problems. Those varicose veins are a source of phlebitis and this kind of thing. So I think it's important, and it gives the patient also a very good, cosmetic result by doing the microphobectomy and getting rid of them completely. So in summary, this guy, middle-aged guy, like we said, he had two risk factors for venous insufficiency, or for developing venous insufficiency, and
standing up at work,
standing up at work, and the strong genetic component with his mother. What was his clinical stage? We talk about the SEEP classification. He was symptomatically moving, from a C2 to a C3.
C6 being the worst.
C6 being the worst. And C3 indicates that the patient has swelling. And he was starting to have that. So he was kind of early stage 3, which is a good time to get treated, because, again, like you mentioned before, venous insufficiency and venous disease, it's a progressive process. Mm-hmm. If you don't stop the process, it will slowly get worse with time. And, C3 is swelling. C4 and above now has to do with skin problems, and we don't want the patient getting into that situation. We're going to talk about that more with our other two patients. So treatment, fairly straightforward. He did fine. He had a good result, fairly complete resolution of his symptoms. He many people work through these procedures. Mm-hmm. Many people who don't want to miss work, they don't have to. If they don't want to, I think this guy missed a day or two at the most. People will have a tiny little bit of discomfort for a little while afterward, but that goes away in 6-8 weeks. And when I say a little bit of discomfort, it's very, very minor. They can certainly work and do normal activities.
Yeah, I can testify to that because the first days, there's a little discomfort. After that, it's minimal. And then it takes a while to go away, but it does go away.
Yeah,
I
right,
like
that. Right. Of course, with him, we advised him to wear, get in the habit of wearing compression stockings. And, what I tell pretty much, most of our patients, almost all of our patients, is that even after they get treated, it's a good idea to incorporate compression in one way or another into their daily activities. And, for those people that are working, that work day to day, that's a perfect kind of thing to incorporate is wear compression during the work day, whatever days those are. And, it's just a knee-high compression does the job, especially for someone like him who, he works as a cook. He's on his feet all day long. He has to have compression. And
on both legs, you say?
Yeah, both legs. That will protect the work that he's had done on the left leg in this case. It will also hopefully delay and very possibly avoid him having these kind of problems in the other leg, with time. Mm-hmm. Now, again, the genetic influence of it that any one person has is the same in both legs. And, is it likely that he will develop something in that opposite leg, the right leg? Yeah, but it may, if he wears compression consistently, it may be, pushed back. It may be less. It may not require intervention, whatever. But so wearing compression is a good thing. And then surveillance will, monitor him in the future. And if he has any recurrent or new symptoms, we will certainly get him back for an ultrasound. And that's the way we treat that kind of patient.
Okay, and before we go to case number 2, everybody, let's remind you that Dr. Juleff has four shops here on in Hawaii, Big Island, Maui, Kauai, and here on Oahu. And if you want to know more, I suggest the website. You can see a lot of the things we're talking about. You can see pictures and diagrams and learn some really great stuff by going to veinclinicsofhawaii.com, veinclinicsofhawaii.com.
Okay, case number 2. This is a 55-year-old gentleman who worked in construction all of his adult life. He also presented with a primary complaint of varicose veins. He came to us because he identified varicose veins in
both
his
legs.
Both legs, for him, both legs. And they had been developing over about a 25-year period. He had never, up until he came to see us, he had never had, formal evaluation for vein disease or venous insufficiency.
Wow.
So,
bet you changed his life.
Yeah, for sure. So for the better part of 10 years, out of those 25 that he, 25 years previously had identified something, but for 10 years he started developing again the usual symptoms: achiness, heaviness, fatigue. In both legs. It was worse on the left, and in these symptoms alone gradually worsened again with time, not surprising at all. That's the usual scenario. This in particular, the symptoms continued to get a fair bit worse on the left. So he was growing more and more concerned. So for a couple years, symptoms were starting to interfere with his ability to work. So again, that kind of that's sort of
that's the little silent alarm that starts going off.
That's a warning sign. Yeah. He had not tried compression, when he had come to see us. So he was just kind of working day in and day out, and just tolerating the symptoms that he was having. But he started to note swelling of the ankles and feet, and sometimes at the end of the day he had a hard time putting his shoes back on if he would have taken them off.
Yeah.
So that's it
Boy,
sounds
me
funny.
too, pal. I just don't take them off.
It sounds funny to people who don't have that problem,
yeah, exactly.
but we hear that all the time,
especially on airplanes. I bet.
Yes, exactly. People take their shoes off on a long flight.
Yeah, now you're 2,500 miles from home in an airport with shoes that don't fit.
Yeah, exactly.
Ouch.
They're walking through LaGuardia in their stocking feet. But so the swelling, we ask about this because this is kind of an important point. The swelling went down overnight. So, he'd go to bed with a fair amount of swelling, but by the morning it had gone away, which is a good sign because that means that just, the elevation, and he wasn't even elevating his feet. He was laying flat in bed, but just that, recumbent position was enough to allow the swelling to go away. So that's a good sign because it kind of indicates to us that if we eliminate that problem, then hopefully we can get him back to having, minimal to no, swelling. He had also noted brownish discoloration of the skin around the ankles. So here we go with, skin problems.
Yep.
And like we mentioned before, C3 is swelling, but when we start to have discoloration of the skin and other problems, we get into that higher echelon of the clinical classification, which is C4 and above. So that's always a bad sign. We don't want that to happen. But plenty of people come in with skin changes. The skin was becoming thickened and rough in texture, and again, this is something that happens as the process goes on. The skin also can become, rashy and itchy at time, and this was happening to, I believe, in this patient, the left side. So he was developing not only that discoloration, but he was also developing that thickening of the skin, kind of rashy kind of appearance and itchiness, which again is these are all very, very standard recognized symptoms for venous insufficiency. And again, the skin changes on him were worse on the left. The thing that we started to get concerned about when we see skin problems is ulceration. And luckily, he had not had an active ulcer. However, he had noticed that whenever he would scratch himself, or if he had a little injury to the skin for whatever reason, whether it was at work or, working out in the yard or whatever, he had started to notice that it was taking him longer to heal those things. Mm-hmm. So they would heal, but they took a longer period of time. So this guy, again, he's got varicose veins. That's why he came in. But the picture is sort of broadening here as we talk to him more and look at his legs and go through the whole thing. So
it seems to me that no matter what got in there, that it was at the exact right time for this particular patient. If it maybe 3-6 months later, it would have been considerably worse than it is when you saw him.
Absolutely.
Yeah, that's what I'm thinking.
Absolutely. Yeah. So,
that's kind of how I was. If you ignore this, listen, I know there are people out there listening. You guys have got these symptoms, and gals too. And just because we're talking about two guys today doesn't mean we're talking about not girls. This is everybody. And the quicker you say, that might be me. Mm-hmm. I found great comfort, and I'm sure all of your patients do, when it's 6 categories, six stages of disease. Mm-hmm. You need to know where you are.
Yeah.
and where you're going, and,
Sure.
and how do you lessen that? How do you put more time in that, or how do you deal with it?
Yeah. I think you're right. I think the people do have a certain amount of
I know. I'm certain of it.
And we have plenty of people. Although these 3 patients we're talking about today, they came in because they had varicose veins. But a lot of people come in and they're not sure what they have. They're not sure what the problem is. And when we're able to define it for them completely with our evaluation, the ultrasound, and we give them kind of that the idea of that clinical spectrum in classification, and I think that they do feel better for sure.
Yeah.
So this, as far as the past medical history, he had this patient had high blood pressure. Otherwise, he was healthy. He was slightly overweight. But certainly,
aren't we all?
He would, he was not morbidly obese, but he had a few extra pounds. But
by the way, gang, Doc knows I was morbidly obese, and I know the big difference now being. I might be 5 pounds heavier than I should be, and you might be 1 pound heavier than you should be because you're in good shape. But it's great to know that when you can correct one thing, when you can deal with one thing, it has impact on others. Like this guy being real. If he was morbidly obese, we'd be talking about different symptoms and different practice and different treatment.
Mm-hmm. Yeah, for sure. So he his family history. Yeah, father. Actually, this guy, both of his parents had venous disease. Yeah. So his father had varicose veins. But he didn't recall that he had other, his legs otherwise looked fairly normal, as the patient remembered. The mother did have varicose veins and some discoloration, but the patient remembered that the mother had a fair amount of swelling that she dealt with, over the years. Neither parent was ever treated, but so this guy, unfortunately. He's got a double whammy. Yeah. He's got his mother and his father, so he can thank both of them. We did the ultrasound, and on the left we saw axial reflux. We say axial, which means that there was reflux throughout the entire length of the vein, the great saphenous vein. There was also on the left, unfortunately for this guy, he also had deep venous reflux in the what are called the femoral and popliteal veins. Those are just 2 major, veins.
Those are the big ones, way inside.
Yeah, right? Those are deep, and they're bigger and they carry more blood. Now on the right side, he had reflux in both the great saphenous and the small saphenous. But those are both, the superficial venous system, but. The fact that on the left, which was his worst leg, clinically it was worse, he had superficial reflux as well as deep reflux, and that was really the reason why he was having more symptoms on that left side, that deep reflux. And it was fairly extensive. Sometimes we see a little bit of deep reflux that kind of coexists with superficial reflux, and when we correct the superficial, that focal deep reflux may go away. But this guy had definitely a fairly extensive amount of deep venous reflux. So how are we going to treat him? Well, similar to the first patient. On the left side, we're going to do endovenous ablation of that great saphenous vein. It was just one superficial vein in the left leg that was problematic. We treated that, and then we did, again, microphlebectomy of the varicose veins. We also did what's called ultrasound-guided sclerotherapy, which, sometimes we incorporate that into our treatment plan, and that just means that we use the ultrasound machine to identify sort of secondary branches off of those saphenous veins, and we inject them to kind of bring about a more complete closure of the saphenous system that's not functioning well. So that was the left side. We did phlebectomy to get rid of the varicose veins. On the right side, we did endovenous ablation of both the great saphenous and small saphenous, as well as phlebectomy of the varicose veins and ultrasound-guided sclero. So what about the deep venous reflux? Well, unfortunately, do we have surgical procedures to address deep venous reflux? Well, yeah, we do. Unfortunately, they're not as reliable.
Yeah, I was going to say it's a pretty big deal.
As the procedures that we have to correct superficial venous reflux. There are potential complications that go along with those procedures. Sometimes the procedures are not real durable. So some people we're going to treat, some people we aren't. And in this guy, probably what we're going to do is we're going to see how he responds to our treatment that we've done. We're going to see how we can control the swelling, because that's really the the crux of his problem with respect to this left leg, especially because he had more swelling in the left side. Is control of that swelling. The swelling that persists because of the deep venous reflux, the swelling that persists, can create problems in the future. Again, primarily with the skin, and we don't want him, progressing with the the skin problems that he was having. So, we're going to rely very heavily on compression. We are going to rely on elevation. We encourage people.
My two best friends, by the way, folks.
Yeah.
My compression socks that I have on religiously, even when I'm not with the doc, like yesterday or tomorrow, and then of course, on the weekends, and I find them. I'm wearing them more, but also elevation. It's so simple, particularly at night, when we talk about all the other things like restless leg and all of this kind of elevation is wonderful.
Yeah, and I think people often don't understand the importance of elevating their legs, because we say elevate your legs, and they go well
they put them on a footstool. That's not elevated. No, that's a footstool.
Right. That isn't very good elevation. But we go through all the process. But elevating is important, and it can create it can have a great benefit in controlling swelling. Now, if we can't control swelling, then there are other things that we can do. There's massage, and there's what we call sequential compression devices. They're a little more elaborate. They're more difficult to contend with for the patient. So we kind of start simple and then get more complicated if we need to.
Okay, so this guy then, so that pretty much takes care of our guy. This guy.
Yeah. So, middle-aged guy again, strong genetic component. He was, our first patient was kind of early C3. This guy's 4B, moving into bad territory with the skin. And again, we need to monitor him probably a little more closely. So, we're going to treat him, and then probably in 6 months have some contact with him and see how he's doing, making sure that things are improving. And if they aren't, then we're going to have to do further evaluation and possible changes in his conservative therapies that are going to have to go on. So patient number 3, again, a middle-aged male. We're
okay. Just hold your breath there. Just to remind you, everybody, you're listening to Dr. Randall Juleff, the medical director of Vein Clinics of Hawaii, and these cases and others. And we so love you listening. You can send us an email. You can get a question and answer, but you should go to the website and check out, because everything we're talking about you can see in one way or another there, and listen to some of our other shows. And that's veinclinicsofhawaii.com. Veinclinicsofhawaii.com.
Yes, and you can also ask questions.
Yes,
there's a little place to click on, and if you want a question answered during one of these programs, we're more than happy to field those questions. So please feel free to leave your questions. Case number 3, he's 63 years old, so middle-aged male. Also presented with varicose veins. He owned a car dealership, and he had been involved in sales for many years. He presented to us again with his primary complaint was varicose veins, although he had other problems going on also. He had developed his varicose veins, or he had first noted them about 30 years prior to him coming in. So when he was in his early 30s, he was starting to develop varicose veins. And he was treated, I guess, on just the left leg. He actually underwent treatment for his varicose veins back then. So when he was a young man, he underwent vein stripping. That was just in his left leg
at age 30.
Roughly early 30s. So now he has varicose veins on the right in the area of the inner thigh and inner calf. He has varicose veins on the left, on the front of the thigh that wrap around the outside of the lower thigh and into the calf. So he's got new varicose veins on the left. He's got new varicose veins on the right. However, they've been kind of getting worse over a number of years. He also has a fairly substantial amount of chronic swelling in both feet and lower legs. The swelling extends up to the knee. When we look at swelling, we see how far up the leg it goes. So, if it's just in the feet and ankles, that is, that's a little, better kind of situation than swelling that goes up to the knees and above. So he had more swelling. He had swelling that actually went to, mid-calf, almost to the knees. He had what we would refer to as advanced skin changes. So not only did he have the brownish discoloration, but he had the real thickening of the skin, and the texture of the skin becomes rough. It was
like leather.
Like leather. Yeah. So the skin can become very, very fibrotic, and when we try to work with those patients, you can feel how fibrotic and almost scar-like the skin can be, and it makes it more difficult. Just doing injections through very abnormal skin like that
Pretty
can
tough,
be
huh?
can be difficult.
Isn't it amazing? And you've expressed this before. How long some people will tolerate something before they get something done. Yeah. And, they just, it's sunburned. I came up with every reason before you started treating mine. Right. And, and by the way, it's a pipe dream to think that skin's going to return to what it looked like when you were 16. Yeah.
Unfortunately, even after we treat people, which is one of the first things people ask us is,
how come it's still brown?
Is that, Is the discoloration going to go away, especially the ladies that we have? Yeah. Unfortunately, it might lighten a little bit after we, fix the venous reflux.
Yeah, and it does. Mine have. But the other thing is, it's a real good reminder, because if you ever see a change in that, when you think you're going around, then whoops, it may not be on my regular schedule, but it's time to go see the doc.
Right, right. So again, he had fairly advanced skin changes on both sides. It was worse on the left. He had suffered non-healing ulcers on a couple of occasions of the left ankle, and that was over the course of the prior 12 months or so before he came to see us. He had been seen in a wound care clinic, and the wound care kind of scenario helps get those wounds healed. And if they're going in on a weekly basis and they're having those wounds cleaned, and especially if they're using some compression, and there's a whole host of new kind of products that can be used to enhance wound healing.
A lot of that is silver, isn't it?
It's
amazing.
A fair bit is silver based.
It's amazing to me.
A fair amount of silver based, but so he'd gone to the wound care clinic and it got healed. So that was encouraging for him. Sure. Although he was never really confronting the underlying the root problem of what was going on here, but. And he also had some dermatitis, so he had some rashy kind of things that was going on in the lower leg too, on both sides. So he would be getting back to our classification system. He was a C6. You know, when he had these active ulcers, he would have been C6.
Sure.
That's the worst level. Right now, he was C5 because those ulcers had healed.
That's where I am. I'm C5.
Yes.
You know, I'm C5. I mean, I'm not really proud of it, but I know what it is.
Sure.
And I know that the next place is not where I want to be.
Right.
So it really, you have to be proactive and do what you can to do the right thing with the compression and everything. And then you got to get to your ultrasound once or twice a year. Then you got to get it fixed.
Yeah. Right. Stay on top of stuff. But so past medical history, he had high blood pressure. He had diabetes. He was on medication for cholesterol, which is not unusual, but he was also fairly obese. He was about 50 pounds overweight. So that's going to, kind of enhance the problem. You know, people who are obese have this thing called lymphedema.
Sure.
And, lymphedema also goes very, very much hand in hand with venous insufficiency. And we see it in particular, those people who are overweight and have venous insufficiency, probably most of them have some component of lymphedema if swelling is part of the of the picture. So he had a number of things going against him. We asked him about family history. He did not recall, any family history. Sometimes people don't, some people.
Well, sometimes family members that have it keep it covered up so nobody sees it.
Yeah, right. I was talking to a lady just over the last couple of days, and I asked her about her parents and whether her mother or father had, vein disease. And she said, well, I don't really even remember seeing my parents' legs that much.
Yeah.
So, so it's kind of hard to assess. But sometimes they don't. And, the parents may not have had, vein problems. But, usually if the parents haven't, then maybe it's a grandparent or an aunt or uncle or whatever. But usually it's in there somewhere. So we did an ultrasound, and on the left, he had an absent great saphenous. That was because he had vein stripping.
That's when he had a vein strip earlier, sure.
Yep. Yeah. He also had deep venous reflux of the common femoral veins, significant reflux in the small saphenous vein, which had not been treated. And he had reflux in what is called the anterior accessory vein. The anterior accessory vein is on the front of the thigh. The great saphenous vein is on the inside of the thigh, and that's a very, very common, vein to have problems, and we treat that vein all the time. He had his great saphenous vein treated by vein stripping
years earlier.
Years ago. So he, as you may recall, had new varicose veins developing on the front of the thigh of that left leg. Usually when people, even if they're treated with more modern techniques for venous insufficiency, if a number of years later they start to develop varicose veins, usually there's a reason. It's not just that boom they started to develop new varicose veins. We evaluate them, and often it's because of the fact that they have developed new reflux. And we see that all the time. Again, it's kind of that genetic influence that just continues over time. So he had this anterior accessory vein on the left that had started to reflux, and that was the primary reason why he had the new varicose complex on the front of the thigh that I had mentioned before. So on the right, he had significant reflux in the great saphenous vein. The deep reflux, let me see, and also he also had deep reflux on the right side. So he had bilateral deep venous reflux in addition to superficial venous reflux. So again, that all of that kind of puts him into a higher. I
was going to say
level.
He's got a lot of risk. I mean,
he's got a fair amount of problems. So again, I mean, this guy has advanced things going on, even though he presented to us because of his varicose veins. So how are we going to treat him? Well, we're going to do endovenous ablation of the refluxing superficial veins. That's the right great saphenous vein, the left anterior accessory, and the left small saphenous vein. we're going to do microphobectomy for the varicose veins, ultrasound guided, and then in this guy in particular, compression.
Yeah, the three, painting. The three most important things about painting is prep, and the most important thing about venous disease is compression. Incidentally, I think this is kind of neat, and I tell you why. Because when you start taking a look at that, how you're going to treat it. This guy is walking down a very well-beaten path, and I would imagine that what you observed about him and what you've done for him have been really lifestyle altering, that he's been able to do a lot more things since he got treated.
Oh, yeah. For sure. I mean, all three of these patients, actually.
And by the way, gang, you will be very handy about talking about great saphenous veins and small saphenous veins and all of these other things once you become a patient, because that's what you get explained. And that's what we're trying to do here.
Yeah. Sorry for all the lingo, but it's hard to talk about this stuff and not use some of those names. But so he's going to be even more closely followed, like you alluded to before. We're going to have to follow him over time. But so, in summary, this guy, again, another middle-aged male. All three of these guys were basically middle-aged males. But the difference for him was that he had bilateral deep venous reflux. Again, that deep reflux is something that is a lot more difficult to eradicate, to eliminate completely. And it's a little higher level of complexity when it comes to not only treatment but just managing those patients over time. And he had a fairly strong component of lymphedema, just by virtue of his obesity and the venous insufficiency. So again, in him, our primary goal is to minimize swelling. We need to to keep that skin healthy over a long period of time. You really need to keep the swelling to a minimum. And I got to tell you, it's not an easy job. It really is not an easy job.
I'm doing that. It's work. I'm doing a little bit of it. And incidentally, always get asked the question: does it help to put, once you've got things under control and you're being treated, does it help to moisturize your legs? Use lotions?
Oh yeah.
I mean, like Lubriderm or whatever stuff. I mean, I understand there's some basic over-the-counter stuff that's really great for you. Helps you a lot.
Whatever it takes and whatever seems to work, for individual people to keep that skin moist, keep it healthy feeling, healthy looking. And that's all good stuff. But people can be, as can be a little resistant to, getting into the habit of making an everyday habit of wearing compression stockings. And somebody like this gentleman, that's exactly what he needs.
Yeah, he's got to do it.
Yeah, he's got to do it. And that's what we spent a fair amount of time trying to convey that to our patients, but it's so important in preventing, ulcerations in the future. And he is at risk. I mean, he's at tremendous risk for developing further ulceration in the future.
By the way, Doc, I'm going to assume that most of the time, like when we talked about the first guy, that was the lightest case. He needs an annual reevaluation. I'm expecting, like me, that this guy needs at least twice a year. Every 6 months for an ultrasound, just see how things are doing. With the records that you keep and the case files that you build, it's really easy to tell this guy, help this guy to stay away from going to the next step.
Yeah. And typically what we would do with a patient like this, a patient like all three of these, but you're right. The different intervals, depending on how severe their venous insufficiency is, where they are on that clinical scale. But in him, if we don't hear from him in 6 months, we're going to give him a call. We're going to say, hey, how are you doing? How are your legs looking? How is that skin, looking? And, do you feel like you need to come in and see us and get an ultrasound and, to kind of figure out where they are at that point?
Yeah, and, one of the things that you've learned with these three different guys is you can explain it one more time, that it was years ago, within the last couple of decades, that this 6 categories were even identified.
Yeah.
That everybody now that you talk with somebody that comes here from Israel and they're living here, but they've had treatment at home, you can find out from their practitioner, and you guys are all on the same page. I think that's really special.
Yeah. The way that we talk about people. Talk about patients, and especially to other physicians or in other other people who are involved in the treatment of that patient. Yeah, it's very, very helpful for sure.
A quick thought, just make sure everybody knows, as we are in the throes of the pandemic, what social distancing and the habits, the best case, the practices going on in your offices.
Yeah, for sure. We're doing the distancing. At every stage. I mean, whether it's the waiting room or it's the treatment rooms or whatever. Obviously, we have to be closer than 6 feet away from the patient to treat them. But we're separating patients. We're sanitizing. Multiple times each day, and washing hands, and everybody wears a mask, for sure. Yep. So, just getting in the habit of that routine, because it's going to last for a while.
Yeah, and don't delay treatment for worrying about that, because it's something you don't have to worry about. Hey, we're glad you could join us this time, and if you like what you heard, and if you don't like what you heard, come back again. We're bound to make you happy. In the meantime, please go to the website and check it out for yourself. That's veinclinicsofhawaii.com. Veinclinicsofhawaii.com. For Dr. Juleff, I'm Mike Buck. Thanks for being with us. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.
Let me be straight with you. This is a radio commercial for 3 Small Business Insurance. The policy has no fine print. It's clear what's covered. So while you can't see the following scene, just know that this pet store is protected by 3.
Joe, did you leave the snake tank open?
Look, I don't want to point fingers, but yes.
It's biting me! Sorry, sir! I'm calling my lawyer.
They're going to need some help with this mess. Luckily, they have 3. No fine print, just exceptional coverage. 3 is a product of Berkshire Hathaway Direct Insurance Company. 3. No nonsense, just common sense.